I'd like to start with conventional taste because it is very basic, and we usually mix the lip powder with anti-cancer drug dissolved in contrast media. So this schematic diagram illustrates the engine architecture of the ACC. This capsule illustrates this nodal ACC, and this part illustrates the extranodular invasion of ACC, and this small nodule means the early stage ACC. And you can see a blue color around the extra capsular invasion part and early ACC. It means that there is a certain proportional persistent portal venous supply. If we start to inject the powder, it initially fills the tumors, and if you continue to inject it, the powder fills the peritumoral portal vein, and then we embolize using particulate embolic agent, so we can achieve complete and devasculate tumor and combine with high dose systemic and chemotherapy agent. But in this kind of case, in early stage of the powder injection, we can see a very good tumor uptake. Never stop infusing the powder. In small ACC, you should continue to inject until the filling of peritumoral portal vein. Otherwise, if you stop here at this stage, maybe this part and this small early stage ACC may survive without complete devascularization. Also, it is important to prepare good ideal immersion. This slide shows the in vitro drug release profile of the powder immersion. If you use normal saline, drug quickly disperse during injection. But if you're using a powder doxorubicin ratio in 4:1 ratio and using iodine contrast media in dissolving doxorubicin, the release profile is much improved. Let me show you a clinical example. Here you can see a hypervascular tumor here. First of all, you have to select tumor feeding artery selectively. Never stop here. You have to continue to inject until the appearance of peritumoral portal vein with lip powder. And this is the ideal endpoint of conventional TACE. Dr. Miyayama in Japan nicely demonstrated the relationship between local tumor recurrence and visualization of portal vein. If the peritumoral portal vein is well filled with lip powder, here you can see the long-term recurrence rate is less than 30%. Actually, our goal of ACC treatment is not tumor control. The ultimate goal is to long-term survival. In determining long-term survival of ACC, there are two major determinants: local tumor control and liver function preservation, because ACC frequently recur even after curative treatment. Here you can see the recurrence rate is more than 50% at 5 years. So if you select, here you can see a small tumor. If you can advance a microcaster up to here, you may have to sacrifice this much amount of normal liver. But if it is possible to advance up to here, you can save a lot of normal liver with maximizing the treatment effect. So it is very important to save normal liver parenchyma as much as possible during your TACE procedure. So that the number one basic principle of TACE is ASAP, not as soon as possible, but as selective as possible to do the procedure, in order to maximize therapeutic efficacy and to minimize normal parenchymal injury. Among competing modalities, actually it is best suited for conventional TACE. Now we have technical support such as microcasters and cone beam CT. Nowadays we have good technologies, cone beam CT machine, and very low profile microcasters, and also intelligent guidance software. However, if you have all these technologies, additionally the experience and dedication of interventional radiologist is required. In intermediate stage of ACC, actually conventional TACE is the primary option, but nowadays we have competitors, step TACE and also radioembolization. There are various kinds of drug-eluting beads available in Asian market. This bead, Hepasphere, LiPo, and tandem microspheres. All these microspheres absorb doxorubicin, positive charge doxorubicin by ion exchange mechanism. As you can see, the drug is loaded on the surface of microspheres. This slide illustrates how depth TACE works. The same diagram. So if you inject microspheres, it is quite different with previous diagram. In the previous large size gel form usually block the vessels outside the tumor, but microspheres are basically enter into the tumor vessels. The ideal endpoint of depth TACE is disappearance of tumor blush, tumor stain. It means that intratumor vessels are well occluded. And then drug slowly released into the tumor, and then a devitalized tumor. Combined ischemia combined with anti-cancer drugs. However, as you can see, the peripheral part of extracapsular invasion and early stage ACC may survive because it is partly supplied by portal vein. The microspheres never enter into the portal vein. I will show an example. Here you can see a large tumor on the right lobe of the liver. Because of the size, I selected 100 and 300 and 300 to 500, 2 vials of drug-eluting beads, and at the end of the procedure, here you can see multiple blood pools and some residual stain. Maybe you can embolize with gel foam or any other material. Actually, I stopped the procedure and followed the patient On follow-up CT, most of the tumor was necrotized. And this is the follow-up angiogram without any further embolization. This blood pools disappeared and small residual viable tumor remained around the tumor. So I repeated second session of that TACE, and the tumor was completely necrotized. If we compared conventional TACE and that TACE, there are some differences. Drug elution profile is better in that TACE. Drug is slowly released. If you compare the penetration, the Lipiodol is better because the Lipiodol can enter into portal vein and tumor capsule, also in liver capsule. However, drug bead cannot enter into those small vessels. How about the quality of embolization? Basically, that TACE is a permanent embolic material, but in conventional TACE, we usually use gel foam so that it can be transient. If you use very tight embolization with the gel foam, it can be permanent. How about level of embolization? Usually, the gel foam embolizes vessels more proximally, but that TACE, the particle size is smaller and round and do not clump each other, so it usually embolizes the very distal vessels. So in terms of selectivity of procedure, conventional TACE is better than that TACE, and endpoint is somewhat different. In that TACE, they recommend near stasis rather than complete stasis. So as you can see, there are differences in the quality of embolization. So to improve the efficacy of conventional TACE, small calibrated embolic materials, including small calibrated gel foam or small PVA particles, should be used to improve the quality of embolization. How about the survival outcome? There are 3 randomized trials comparing conventional TACE and DEP TACE. 2 randomized trials was done with overall survival as endpoint. This trial is the best one, and they demonstrated no difference in tumor response rate between conventional TACE and DEP TACE. And also survival was exactly same between 2 treatments. The only difference was post-procedural pain and in hospital stay, only 1 day difference. Of course, it is longer in conventional TACE. Meta-analysis also demonstrates no difference in survival. And there are 2, how about the complication of the procedure? We can find 2 reports comparing conventional TACE, DEP TACE about biliary complications. Both papers reported 2 times higher biliary complication in DEP TACE. But please remember that these reports are based on rather non-selective procedures. So if you perform DEP TACE very selectively, there is no risk of biliary complication. Here you can see a small tumor in right posterior section. The right posterior section artery was completely embolized with drug-eluting beads. After that, you can see the tumor was completely necrotized. However, in addition to tumor necrosis, you can see biloma formation and thrombosis of portal vein, and then the whole right posterior section was atrophied, underwent severe atrophy. So even in that case, it is very important to perform the procedure in very highly selective fashion to avoid biliary complications. How about the efficacy in small ACCs? In small ACCs not well encapsulated, And frequently it is vaguely nodular without distinct capsule formation. In this case, at the boundary of the tumor, the portal supply and the hepatic supply is intermingled, so that it is not possible to completely control with deptase. This is the outcome of Korean multicenter registry in the single-arm trial. Here you can see the best outcome was achieved in tumors between 2 to 5 cm in size. If you look at the tumor smaller than 2 cm, the response rate is worse than the tumor between 2 to 5 cm. Basically, the response should be better in smaller tumors. It means that deptase do not work well in small ACCs. So this slide summarizes the consensus comparing conventional TACE and deptase. Overall survival is same, systemic toxicity may be same, and the difference is post-embolization syndrome is higher in conventional TACE. Cost is more expensive in deptase, and in small ACCC, conventional TACE should be better. How about the radioembolization? This is yttrium. There are two products available in the world, TerraSphere and the SolarSphere. This slide summarizes the difference between two TerraSphere and the SolarSphere. The major difference is the number of particles, much smaller in TerraSphere. And basically, Y90 is a 100% pure beta emitter. The physical life is 64 hours, and the maximum penetration depth is about 1 cm, so it is quite safe to the patient. If you compare the SolarSphere and the TerraSphere, now you can easily see the difference in the amount of particles. The size is about 35 micron. This is a hair size. This slide illustrates how it works. This radiating particles is very small. This is 35 micron. So it usually never embolizes tumor vessels. It is deposited in the tumors and then radiate beta rays and then devitalize the tumor slowly, not immediately. I will show you an example. He's a child A patient, good liver function. And here you can see a large nodular tumor. Of course, this tumor can be resected, but he underwent radioembolization. Here you can see a feeding artery. In the radioembolization, the first step is to evaluate lung shunt fraction. And we have to calculate the lung safety limit and the liver safety limit and the tumor effect limit, and then decide the final dose of yttrium. The radioembolization performed. After radioembolization, you can see all of the vessels are widely patent, even after Y90 injection. After that, the tumor slowly decreases in vascularity in size, and tumor markers rapidly decreases. 3 months, 6 months, 2 years, the tumor was completely necrotized. These slides summarize the difference between conventional TACE and radioembolization. The mechanism is totally different. The ischemia and the chemotherapy, but the radioembolization, internal radiation. In terms of penetration depth, conventional TACE is still better. But embolization, radioembolization is basically a minimal embolization, so that the patient is very comfortable, no severe post-embolization syndrome. However, the big difference is the selectivity. Conventional TACE is very, very selective, but rate embolization is basically a lobar or sectional or something, so it's less selective. Procedural complexity is more in rate embolization. Post-embolization is more severe in conventional TACE. Cost, of course, is more expensive in rate embolization. How about the survival outcome? Unfortunately, we do not have phase 3 randomized trial because the clinical data did not show any difference, so that it is not possible to demonstrate survival advantage of rate embolization. We have small phase 2 series. Those retrospective series demonstrated no difference in survival. Recently, one phase 2 randomized trial was published by Dr. Salem. He compared conventional TACE and DEP TACE in BCLC A or B. As you can see, tumor size median was only 3 cm in size, and 5 patients were randomized. And they demonstrated time to progression was much better in rate embolization. Conventional TACE, most of tumor recurred, but I cannot believe why the outcome of conventional TACE is so bad. But if you look at the long-term survival, it is exactly the same. How can we explain the time to progression is much better in the rate embolization, but survival is same? I believe it is caused by non-selective procedure and more liver damage in rate embolization, so that to minimize the deterioration of liver function after rate embolization, it is also very important to perform the procedure in highly selective fashion. Meta-analysis revealed no difference. And recently, randomized trials comparing rate embolization and sorafenib in advanced ACC, all those trials failed. So among the randomized trials listed in trial site, all failed, and only one trial is remaining. It is a STOP ACC trial comparing rate embolization plus sorafenib versus sorafenib alone. Maybe in the end of this year, maybe you can see the outcome. So this slide summarizes the consensus between TACE and rate embolization. Overall survival, same. Time to progression is better in rate embolization. And quality of life and post-embolization syndrome is better in rate embolization, but cost is more expensive. And selective delivery is better in conventional TACE. The advantage of rate embolization is absent or mild pain during and after TACE. Rate embolization, shorter hospitalization period, and less treatment session. And it is better efficacy in portal vein thrombosis, but it is not well proved. And it can be an alternative to TACE plus portal vein embolization. Disadvantages are inconvenient, pre-evaluation is needed, not visible, is not comfortable to IR doctors, and the less selective procedure, so higher chance of delayed liver injury. If the non-target embolism occurs, it causes very severe complication. This is the AASLD guideline, recently revised. They say AASLD recommend local regional therapy in T2 or T3 ACC over no treatment. And the AASLD do not recommend one form of local regional therapy over another because there are no evidence one treatment is better than the others. This is EASL guideline. Here you can see the chemoembolization is very high level of evidence. The radioembolization is here. So this slide summarizes the comparison between conventional TACE, depth TACE, and radioembolization. In penetration depth, Repower is best. In pain and the vasovagal reaction after procedure, Repower is the worst. In quality of life and post-embolization syndrome, radioembolization is best. Time to progression, radioembolization is best. Selective delivery, conventional TACE is best. Hepatic damage, because it is selective, conventional TACE is best. In hepatic damage, and overall survival is same, and cost is cheapest in conventional TACE. In conclusion, conventional TACE still plays a major role in management of ACCs, especially in countries with good surveillance program for high-risk population. Appropriate use of depth TACE and radioembolization may give a positive impact on the outcome of intraarterial treatment. Thank you for your kind attention.
Thank you, Dr. Thank you, Professor Lin Wok Chung, for your very excellent lecture on TACE, depth TACE, and radioembolization. So the last topic, I would like to invite Dr. Liu Cheng-an, who will present the topic, Taiwan depth TACE experience and technical recommendation. And after Dr. An, so we should have some minutes for discussion.
Thank you, Professor Tang, and for your kind introduction. I'm Dr. Liu from Taiwan. It's my honor to be here, and thanks for the VSI Congress for inviting me here. So today my topic is to share the experience of the depth TACE in Taiwan, and we recently have the technical recommendation, and also want to share with all the experts in this room. And it's very stressful to have a talk after Dr. Chong. And I think Dr. Chong have already have the very comprehensive review of the difference between the conventional TACE and the depth TACE. So in Taiwan, the HCC is the second leading cause of the cancer death. So, and IR plays an important role in HCC treatment, such as ablation and embolization. So it's very important for IR doctor to standardize our procedure and to improve our technique. So today my topic will divide into 3 parts. The first part is the general concept and the evidence of the depth TACE. The second part is the multi-center experience of depth TACE in Taiwan. And finally, I will introduce the consensus and the technical recommendation from my country. So as we know, conventional TACE, because that is a standard, one of the standard HCC treatment, especially for intermediate stage HCC, but based on the OEO-based agent, so early release of the chemo agent may cause the liver toxicity and the systemic side effect. So for pharmacokinetic characteristic of depth TACE, the drug in routine beads can hold the drug very tight and cause a slow release and high concentration of the intratumoral dose. So that should be better for the cytotoxic effect and embolic effect for HCC. So this is a case of 47 years old male. As you can see that pre-treatment, there is a hypervascular tumor near 5 centimeters in the liver dome. After the depth TACE treatment, 2 months later, the alpha fetoprotein drop to nearly normal level. And you can see that from the CT scan, there's total necrosis of the tumor. So that is a good case and a good candidate for diabetes. So as you know, the Precision 5 study, which is published in 2010, is a landmark trial for drug-eluting beads. Also, it failed in the primary endpoint in the treatment response. However, in the subgroup analysis, in the advanced disease such as child-pugh B, ECOG1, biloba disease, and recurrent disease, the diabetes achieved the better response. And also you can see that the liver toxicity and the doxorubicin related side effect is less than conventional TACE. So this is another case which was treated with Y90 before. However, there's a poor response of the Y90. So we do the selective embolization by diabetes. So as you can see, after treatment, the two tumor necrosis nearly total. And in the follow imaging, you can see maybe there's some feeding artery or recurrent part over here, but overall the response is very well. So another case for mega tumor more than 10 centimeter. This patient underwent multiple times diabetes treatment. However, it's just a partial response. But I want to show you is that based on the selective embolization of the diabetes, the total bilirubin nearly not as compared with conventional TACE, no significant elevation of the total bilirubin after treatment. Also, you can see that the ALT level keep nearly normal after all the treatment. So that means that the diabetes, if you use it very adequately, the liver toxicity is very low. So particle size does matter. So in animal study, the particle size less than 300 meter can be detected within the liver tumor. And the bit size more than 300 will just detect outside of the liver. So in the in vivo study show that if we use more smaller beads, it can cause the higher survival rate and the lower complication rate. Another study showed lower rate of toxicity and more computer imaging response by using the beads less than 300. So as the technology developed, we have more smaller beads near almost around 100 micrometer. So in this study, you can see that for the smaller tumors, you can get more than 50% necrosis, complete response and partial response. And this picture shows that the small HCC less than 3 centimeter, and the histology shows the beads will penetrate into the tumor and also the feeding artery. So the histology results show that 10 out 28 patients have the complete nearly 90% necrosis rate. So that means deeper penetration can cause more necrosis of the tumors. So in 2011, recently, Italian group, Dr. Alberti, they published a 4-year experience by using the M1 beads, which is the size is around 70 to 150 micrometers. And the inclusion, interestingly, they include BCLC C-stage patient nearly half. So let's see. Let us see the result. So by the tumor response, you can see that the tumor response achieved the good response at 6 and 9 months. Nearly 90% patients have the object response rate. Compare with previous studies using the more large bead size, the response rate, objective response rate is higher. And also you can see the overall survival is 42 months. But don't forget that they include nearly half of patients is BCLC-C. So compared with the previous studies using larger beads, the overall survival is a comparable result. So as Dr. Chong have mentioned that the complication of diabetes such as bilobal malformation. So this is what we need to take care and then be careful when we do the diabetes, because the peribiliary plexus blood vessel is near 20 to 60 micrometer. So if you use the bead size closely to 60, that may cause the embolization of peribiliary plexus blood vessel. So that may cause the biliary stricture and the subsequent bilobal malformation. So this is the case. You can see that this patient refractory to conventional TACE with multiple recurrent viable tumor over both lobes. And from the angiography, you can see the feeding artery is very fine, and we choose the smaller beads. However, after 2 times treatment, fever and sepsis occurred, and the follow CT image shows the multiple bilobal malformation. That means the bile duct necrosis with multiple bilomas. So till 2015, there are at least 15 published data compared with step TACE and conventional TACE. However, there are most of the data are from Western countries, but there are 2 from the East. So let me look at that. So this is from Korea. So by using the diabetes, they found that the the response rate is higher in drug-eluting beads, and in the more advanced stage patients, such as BCLC-B, this patient, you can get more time to good time to progression and response and the survival as well. So another data is from Taiwan, published by Dr. Liu. So he compared with the conventional TACE and the diabetes by divided the all patients into 3 groups. So the follow-up is, this study is short-term follow-up, and every patient, the M follow-up time is nearly 16 months. So the inclusion criteria for 3 groups patients are similar, but for the result, you can see that the DCB's group, we can inject more doxorubicin, more chemo agent into the tumor, and there is less liver toxicity when we look at the data of AST, ALT, and the bilirubin ratio. And there is less adverse events such as fever and abdominal pain in drug-eluting beads group. So how about the response? The response showed that there's more complete response in diabetes group and less progressive disease in diabetes group. And the time to progression can be longer in the diabetes group. So when they add another BCLC group into the analysis, you can still find that the median time to progression is still better in diabetes group for 5-year long-term outcomes. So the short conclusion is that the diabetes for short-term outcome, it may have higher complete response and lower progression rate and a better safety profile. For long-term outcome, we found that the less patient die and the long time to progression. So let's move to the multi-center experience in Taiwan. I will show you three. Most of the data is unpublished. So this is from the Tainan, one of the south city in Taiwan. So they compare the conventional taste and the depth taste. So finally, the median progression-free survival is longer in depth test group with significant difference. So this is another medical center in the South Taiwan, and I think it's the biggest liver transplantation in Taiwan. So they use the DCB's taste in 240 patients, and then the response rate, short-term response rate is over 70%. And the 3 years survival, as you can see that compared with conventional taste, the survival rate is higher. And when you see the Kaplan-Meier survival curve, in the stage A and the stage B patient, even in these two groups, they did not reach the median survival. That means that their survival is very good. So they also analyzed the patient underwent depth taste when they put this patient into transplantation waiting list. So they get the result that if you use depth taste, you can get a successful downstage rate nearly 70%. Beyond when the patient initially is beyond UCSF criteria and then downstage to UCSF criteria. So this is another medical center in the middle of the Taiwan. So similarly, the response rate is nearly 70%. And the best response of the patient are located at the 3 to 8 centimeter, which is very comparable to other studies and also Dr. Chong's statement. There are some meta-analysis, but most of them come from China. This is early meta-analysis. So the conclusion is that significantly better object tumor response rate was found for depth taste than conventional taste. And this is a recent meta-analysis which are published. And they enrolled 16 cohort studies, 4 randomized control trial, 3 prospective cohorts, and 9 retrospective cohorts. So they analyzed the patient and found that depth taste is improved 1, 2, 3 year overall survival rate and 1, 2 year relapse-free survival rate. So in 2012, Dr. Lencioni from Italy, the group published the technical recommendation for depth taste. So I think the Eastern doctors are always more aggressive than Western doctors, and one size cannot fit all. So based on the Taiwanese doctors' experience and the published data, we decide to make a technical recommendation in depth taste. So in this kind of case, because we want to standardize our procedure and to achieve better outcome, such as this tumor and this big tumor complete response after depth taste. So this is a panel of all the experts from the interventional radiology and also gastroenterology, hepatologists. So we review all the literature and made the recommendation grade from grade A to grade D. So let's look at the patient selection first. We use in Lencioni's paper, he didn't mention about the patient selection criteria, but we think that is very important because if you can choose the good candidate, you can get a good outcome. So based on the apostle consensus on treatment of SCC, we enrolled the patient within Milan, outside Milan with hepatic vein or portal vein invasion into our patient selection criteria, such as that. But I think personally in the hypervascular medium-sized tumor, you can usually, if you do the super selection, you usually can get the good response. For large tumor, mega tumor, you may need a sequential treatment or combine with other local regional treatment. And if you treat the multiple bilobus HCC, you should be very careful about the too aggressive the embolization, because when you put the catheter in the lobar, that sometimes it may cause the over-embolization. And for portal vein invasion to VP1 and VP2, our experts agree that this kind of patient can be treated by deptase. However, in VP3 group, we think that this patient may need complementary radiotherapy, such as SBRT, to treat the portal vein thrombosis. And the portal vein VP4 is a relative contraindication for the deptase. So how about the planning dose for doxorubicin? The recommendation is B, based on the review the literature and the consensus. For the tumor stage within Milan criteria, we suggest that you can use the 1 vial of the drug-eluting beads, and the loaded doxorubicin is less than 75 milligrams. And if the tumor stage is beyond the Milan criteria, as a general rule, you can use 2 vials of the drug-eluting beads with the loaded drug to up to 150 micrograms. So if there is a bilobar big tumor, sequential treatment with 4 weeks apart is reasonable. But of course, you can treat this kind of tumor within sensation, but you should make sure that if all the tumor is adequately embolized, or you can do the sequential treatment. But compared with the Lencioni recommendation, they suggest that in this kind of case, they suggest a separate treatment session by 2 to 4 weeks, which is a little difference between these two consensus. How about the beads? The size. Size is very important. Use the 100 micrometer bead size is recommended for standard procedures. And if there is significant AP or AV shunting, we should embolize the shunt first, and to avoid the beads go to the pulmonary or portal vein. And the tumor size, if the tumor size is smaller than 3 centimeter, we recommend use the M1 beads, and the size is 70 to 150 micrometers. For the very large tumor, you can combine 2 vials and combine 2 different sizes of the beads. You can do small size first, and the other being larger size. So how about the catheter position? Super selection and the selective embolization is recommended first. So that means we should do the segmental or subsegmental embolization. And if you need to do the lobar approach, be careful of the cystic artery or extrahepatic artery to the GI tract organs. So you should, if you found that, you should advance your catheter more distally, or use the coil to embolize these vessels. So let's go to the move to the endpoint. The endpoint in Lencioni's paper, they only mentioned the near stasis, and which means that the contrast column should clear within 2 to 5 heartbeats. But in our recommendation, we think that the first endpoint is the complete obliteration of the tumor stains under DSA. The second endpoint is the near stasis, which means that the absence of the contrast flow in the tumor feeding artery. So, which is the vanish of the measurement of the tumor stain. As you can see, there's a tumor here, but after embolization, it looks like the prong trees without any tumor stain. But the feeding artery is still patent. I think this is a good endpoint. And another endpoint is the vascular lake, which was firstly published by Dr. Seki from Japan. The vascular lake is caused by the smaller feeding artery occluded by beads. And there's a small vessel rupture, and the contrast stayed at the blood space. Let's look contrast extravasation. So that means that they call that the vascular lake. As you can see, this is the typical appearance of the vascular lake. You can see it looks like a GI bleeding contrast extravasation. Not only in the medium-sized hypervascular tumor, if your tumor is smaller but it is hypervascular, you still can see the contrast pulling also, or you can call vascular lake over here. So when you see that, that's another endpoint, and you should embolize these vessels by gel foam or bigger beads. And the contrast pulling vascular lake usually see in the hypervascular tumor, and the percentage can be nearly 25%. So how about the post-treatment management? So if there is a complete response, we recommend the imaging follow-up. However, if there is a residual viable tumor, further treatment is necessary. So it is if you follow the patient by CT scan, and you embolize this kind of patient by drug-eluting beads, you can very easily follow the patient because the viable tumor can be easily identified from the dynamic CT scan. Then you can do sequential embolization, or you can do the sequential ablation and get a very good outcome. So finally, this is table on showed briefly the two recommendations. The left-hand side is the Dr. Lencioni published in 2012. The right-hand side is Taiwan consensus. So there are some difference because we mentioned the patient selection and extend the criteria to portal vein tumor thrombosis of the VP1 and the VP2 patient. And we also suggest that for a smaller size tumor, you can use smaller beads. And if the endpoint cannot be reached, such as near stasis, you can use the gel foam to embolize to reach your endpoint. So this is the last slide. So accurate patient selection of the DEP test, I think, is very important. If you select the patient very well, you can get a good result. And the tumor size and the tumor stage is associated with better response after DEP test. For example, if you see a for a smaller tumor, you can consider smaller size of drug-eluting beads. For medium size, if you use drug-eluting beads, you can get better outcome and less post-embolization syndrome and side effect. For larger size, there is still less post-embolization syndrome, but you need repeated DEP tests and or combination with other treatment. If the patient have the portal vein thrombosis, sorafenib is considered. So additional embolization material should be used in some situations, like when you meet a vascular lake formation or large tumor size. Thank you.
Thank you, Dr. Liu Qian for the nice lecture. And now we have some minutes for discussions. Do you have any questions from floor for our lecture? Do you have any question? I have one question for Professor Wang. Is how do you select the patients for treatment of prostate cancer?
Okay, thank you. Just because cis implantation is a new modality, even in China, most of oncologists follow up NCCN guideline. It's true, maybe the same thing in Vietnam, but most of the time, we will meet that the patient no choice. They have received the surgery, radiotherapy, chemotherapy, and target even immunity therapy. So my patient selection, just from the lost opportunity or no mortality for them. And it is a very, very late stage patient, but there is an indication, for example, expanded survival more than 3 months, and the KPI more than 70, and maybe just the 1 or 3 metastases, not a lot of metastases. If something like that, maybe the survival was very short. So we began from the late stage, and step by step. We spent 18 years to finish the criteria establishment in China at present. So we will spend another 10 years to do randomized trial. For example, we can begin for the early stage lung carcinoma, and the pancreas carcinoma, and the liver carcinoma, and the metastasis of spinal cord, and so on. So this is multiple center clinical trial. So we have to do waiting for the data. Yes, thank you. Mm-hmm.
Any more questions from floor? No? If you have no questions, so we close the session here, and you have a 10 minutes for tea break. And thank you to our speaker. Thank you very much, and come back in 10 minutes. Thank you.